A very good afternoon, everyone. So, before the myope gets to the hands of retina specialist, can we do something? I think that's where I will concentrate on. No commercial interest in relation to this talk, especially, but I have a couple of patents filed, and we do a lot of multiple clinical trials in relation to myopia. Now, this slide should explain it all. Why is the need for the personalized myopia care? All myopes look same, but I think they are a little different, and one size does not fit all. And we all agree that there is no universal protocol to treat the myopia child with myopia, and there are multiple ways, but I think the single agenda worldwide is to ensure the eyeball does not grow any further. So I'll try to justify why personalized myopia strategy is important, and I will take 5 points. The first point is all myopes are not necessarily the axial myopes. Just because we see somebody with -7 does not mean this is an axial myopia, and does not mean we should start some treatment. It could be refractive myopia, cornea is just steep, or it could be keratoconus as well. At times the lens is anteriorly shifted and you see more myopia. In that cases as well, there is no need for us to trigger for unnecessary treatment. And at times it's the refractive index change as well. We do also see a lot of pseudomyopes. Now this is a child 10 year and -7 myopia, and if I just present this information, you would think that okay, let's start some sort of myopia control treatment. But if I show you the axial length, it's only 22.7 millimeters, and you look at the cornea, it's not too steep as well. And then we put the cyclopentolate, and you see that it's actually +1. So clearly there's no point for us to be more aggressive unless you really know this is a case of axial myopia. The point number 2 is to say that not everybody is progressing. Again, let's take the same example of -7. Again, there's no need for us to trigger for some myopia control treatment unless there is an obvious myopia progression. And talking about the Indian context, we see that about 17 to 20% of them have rapid myopia progression, which means 1 out of 5 individuals with myopia needs these treatment options. On the left, you see 12 year, both of them are actually 12 years. And if you look at the case 1, it's -7. Previous prescription, which is 3-year-old, is also -7. Versus case 2, if you see in the last 1 year, it jumped by 1 diopter. So you might want to concentrate case 2, but not the case 1. Point number 3, the mechanisms or the risk factors for myopia are many, and they revolve around near work, defocus in the periphery. Now we talk about contrast in the periphery, light, again dopamine release, or maybe staying away from the near work, or it could be the spectral composition of light or the uniform dipteric field if you are in an outdoor setting. So the various theories, again there is no single theory to say that okay, there's one treatment and I will do that and it will be controlling the progression of myopia. The risk factors are many, and this is much more latest, I think published only a couple of days ago, showing the theories for why atropine could be working. Again, we do not have a clear answer for where the site of action is, but it could be acting at the multiple levels, and these are all the proposed hypotheses. Given that myopia is multifactorial, yes, we do have multiple solutions. But point to note is that the site of action is very different. Bifocals act at the level of accommodation, defocus lenses act at the level of the peripheral retina, and now we have dot technology working at the level of contrast, and we have seen the previous slide, atropine working at the receptor level. So the site of action is very different. Unless you play like a chess, which means you are picking your treatment very wisely, you will not be able to see desirable outcomes. So one thing that I want to indicate is there is evidence to say that all these treatment strategies actually work. This is a living systematic review that we published a year ago, which indicates that high dose atropine, yes, great, fantastic, but it has its own complications. We do not know the long-term complications that the child may have. Orthokeratology, again, nighttime wear. So everything, either there is a cost or there are complications, or we do not know what really works or what really benefits on the long run. So from the optical standpoint, I think there are multiple myopia control options that are made available in multiple countries now, all the way from bifocal to the various peripheral defocus spectacles to the very old orthokeratology. Now, I want to highlight the advantages that we get with the optical myopia control options. Number one, you want to correct myopia anyway. You don't want to leave them uncorrected, so you want to prescribe some sort of optical element. If you can give control also in the same mode, why not? So it's like you do the correction, you also get control, and the compliance is much better. Unlike the eye drops where the parent has to instill, now you're wearing anyway to see things clearly, so the compliance is much more better with the optical strategies. And the emotional stress that the parents or the child has to go with the external agent versus something that they have to wear, I think is much more minimal. Complications again, less or nil. The only worry that we have right now is the cost. That's a bit of challenge, but the clinical trials that we are running, I'm confident that the cost is going to come down. Now, with keeping that in view, the 5 points to say that, okay, now we want to do personalized myopia management, where do you start and where do you stop? So we sort of came up with an impact myopia guidelines published in Indian Journal of Ophthalmology in 2022, involving both the ophthalmologist and the optometrist. So we said impact is an acronym. If you remember impact, the 6-step rule, which can help you to start and stop the treatment. The first one, like I've indicated, is I stands for identify a true axial myope. Eliminate all the cases of refractive or pseudomyopia. Given that myopia is multifactorial, map the risk factors. I mean, as simple as asking them what's their lifestyle, indoor, outdoor. If you have a retinoscope, you can really look at the accommodation, you can look at the phoria, because that will help you what treatment you want to give. Pick a progressive myope. P stands for there's no point just because there's myope, they don't have to be progressive myopes. Unless you have a progressive myopia, there is no point for us to trigger for some unnecessary treatment, as I have discussed already on the 2 cases. Given that we have multiple options, there's no point in shooting in the dark. Otherwise, you will not get desired outcomes. So I think when you look at the risk factors, at times mere lifestyle modifications will give you fantastic outcomes. At times you want to go with the bifocal. When there is esophoria, greater lag, bifocal works great. When you know that there is relative peripheral hypermetropia, the defocus treatment actually works great. I will also quote one of the papers from Hong Kong that indicates that if somebody has relative peripheral myopia, then these DIMS lenses did not show a fantastic outcome compared to the ones who already had a specific pattern. So you might want to really look at that. Again, if you have a retinoscope, if you go a bit off, you will be able to know if it is relative peripheral hypermetropia or myopia. So we say that in myopia management, you want to monitor much more closely, not in every year, but 4 to 6 monthly. If you have a non-contact biometer like LensStar, ILMaster, any of the biometers, you will be able to pick these changes much more easily, even in the period of 4 months. If you're looking at rapid myopia progression, the resolution of these devices is only 10 microns. But if there is a rapid myopia progression, you're going to pick about 100 microns change, meaning 0.1 millimeter. One treatment does not work in 6 months' time, you might want to really think about combination myopia control treatment. Usually we follow monotherapy first. One does not work. There's a rapid myopia progression even with mono treatment. We try to combine the pharmacological treatment strategy. Another $1,000,000 question again is, when do you really stop treatment? There are multiple debates about this. There is no single answer, but I think late teenage is the key word. Just because you see a good myopia control at 8 years or 9 years with 1 year treatment, I don't think you want to take them off given the rebound effect that you're going to see. Now, refractive surgeons consider operating only at a late teenage or 20 plus years, keeping in view of the stability of the eye or the plasticity of the eye. Same needs to be applied here as well, and you might want to taper if you're using atropine. So I will quickly go through 4 cases. The first one is a young adult having a myopia progression, actually came to us for undergoing refractive surgery, but given that there is myopia progression, the individual was referred to the myopia center. And we've seen in the myopia center in 2021, right eye pretty much stable for a good decade, but left eye kept on progressing. And at the time we have seen, it was already minus 9.5. We're talking about high myopia. What do we do? So the axial length also sort of correlates 29 millimeters in the left eye. So we looked at the peripheral refraction. It was a little different in the left eye. When I say different, it was relative peripheral hypermetropia. Now for that minus 9 at that time, we had multifocal contact lens, and anyway there is anisometropia. So keeping that in view, we went on to give myopia control contact lens in the left eye, and you see that the power did not change. I've seen the patient in 2024 March as well, and the axial length was pretty much stable, and we could control the progression. Now, second one, 13-year-old child, and age of onset was 5 years. Points to note are the last three. There is relative peripheral myopia. The moment I saw relative peripheral myopia, I sort of eliminated the use of defocus spectacles there or the contact lens. Then I said, okay, what's the lag? It's 0.75. There is esophoria for near. I said, all right, let me go with the bifocal spectacle. Now, bifocal, if you see this in 4 months' time before treatment, in just 4 months, the eyeball length changed by 0.18 millimeter in the right eye. In 1 year, the changes were only 0.12. So whatever you could see in 4 months because of the intervention, and now good thing was we could see or delay that stretch. Same is the case in left eye. Whatever we saw in 4 months, now it went on to show in 13 months. So we also see that, okay, is it rebound happening only with the atropine? No, the rebound is also seen in optical myopia control treatment options. I will show you with this case. There's obvious myopia progression, and we started them on excellent depth of focus contact lens, and that's the changes 0.08 millimeter and 0.02. Only very happy. Patient did not use contact lens for 4 months. You see that change. In just 4 months, it went to 0.14 millimeter. We said, all right, we use MyoSmart now. Patient did not want to use contact lens, so we used the DIMS technology. We gave the lens, and then we could get the myopia back in control. So I think that this highlights 2 points. Number one, even with optical strategies, you see rebound. And number two, close monitoring will help you to really get things in control. This is again a high myop minus 19 diopters of myopia. Is there an evidence? We said, okay, we cannot leave that individual without any treatment. So this is minus 19, and we gave a partial correction. Whatever we had contact lens, we gave in myopia control contact lens until I think minus 12, and the remainder we put them on the spectacle single vision, and you see that changes are pretty much in control. So why personalized myopia control treatment? I think one size does not fit all. Clearly not everybody is an axial myop. Given that myopia is multifactorial, there are multiple solutions out there with site of action being very different. I think if you shoot in the dark, it may hit, but it may be a miss as well. So I think one case at a time. With this, I thank you for your attention.
Thanks so much, Pavan, for that wonderful presentation. Your first case out of the 4 cases was very interesting. One eye was progressing so much. The genetics is the same, environmental factors, lifestyle, it's all the same. But one eye was not progressing, the other eye progressed so much, and obviously I assume there's no history of any surgery or anything.
No,
so what do you think could be the reasons for that discrepancy?
I mean, usually in case of anisometropia, there is some evidence to say the role of posture of the child while the near work to trigger for greater changes in one eye compared to the other. Maybe there is a different posture for one eye. Now, the second point is in terms of optics as well, we saw that the pattern in the periphery, the refraction, was clearly hyperopic only in the left eye, whereas it was not the case in the right eye, and that could be the reason for why. Now, what triggers the shape of the eyeball, why it has to be very different in one eye, I think is something that we clearly do not know.
So my bigger question is, I mean, this is not a usual case. It's rare to have this kind of so much asymmetry, but overall, are we missing some important factor in terms of myopia understanding, which we still have to discover?
Totally. I think we clearly do not know the markers. Dr. Yam has clearly indicated what could be the triggering factor, and we all rely on the lattice to be some sort of a start point. But before lattice, what could be happening? One of the other cases that we have seen, again, I'm relating largely this to the peripheral defocus. In 5 patients we have seen in the myopia center, whenever there is a lattice in that specific location, we have noted there is significant magnitude of the hypermetropia in that meridian, whereas it's not seen in the other locations. In India, we also see nasotemporal asymmetry in the PR pattern. And in these 5 courses, we saw that. So again, the puzzle is not solved, lot to be looked at, but there are some dots that we could connect at this stage.
Thank you so much, Dr. Pavan. I think we should move